Shanghai. This is Dr. Qiang Tan, a very innovative surgeon. He was also the one who had the idea of data tracking with using a mobile system, and I think he has developed this app and the whole concept to build up a database. And in our institution, he was very innovative in creating an in vivo bioreactor for tissue engineering, and it was a fantastic time when we have developed this concept on chips, and we are interested to listen what you have done in the meantime in Shanghai.
Yeah, thanks a lot, Professor Weder, for your kind introduction, and good morning, everyone. It's my great pleasure to come back to update our project on the reconstruction of tissue engineering. As Professor Weder has mentioned, we actually started this project at the year 2004 here in Zürich, and so it seemed to me today's presentation is like a lab meeting, extended lab meeting, and it's great to see lots of old friends here. And yeah, I'm quite glad to announce that after a dozen years of study, we finally get the chance to test the in vivo bioreactor design in the clinic. So a brief description of the background. And Professor Weder also mentioned I changed the research plan frequently. To be frank, it's not impossible to piss you off, but it's because the tracheal replacement is actually a very tough case. And the father of tracheal surgery, Professor Guerrero, even mentions that it might be impossible to really establish a tracheal substitute because of two main obstacles. And the first one is infection. As we know, the trachea is open to the air, so full of bacteria, and bacteria always grow much faster than normal cells. So whatever a substitute, you said it's perfect, it's with a very good character, and after the implantation, the bacteria will grow inside and cause the leisure pneumonia, and also will cause the overgrowth of the granulated tissue, which will occlude the tracheal lumen. And the second obstacle is actually the delayed revascularization. This is actually a universal problem faced by all tissue engineering reconstruction, because based on today's technique, it proved to be impossible for us to create inside the tissue engineered organ a capillary net, which means a vascular structure, which can be directly connected to the recipient as we did in the organ transplantation. So in that case, right after the implantation, there will be ischemia time, and the majority of the preceded cells will die and will also deteriorate the regeneration niche. So this actually explains why so far in the clinic, the tissue engineering application only limited to the cartilage tissue, which is avascular, and also the skin, which is actually placed on the very well revascularized wound. So to overcome these two obstacles, we advanced new design, which we call it in vivo bioreactor. The idea is quite simple. We use two portable the pumps, and to create a continuous medium flow inside the implanted tissue engineered trachea. The hypothesis is first, the antibiotics inside the perfusit will control the infection. And secondly, the nutrition inside the medium will support the survival of the preceded cells until the vascularization finally established. So this design, we combine the traditionally totally separated the in vivo three-dimensional cells growth and the in vivo regenerational process of the traditional tissue engineering technique, and we actually treat the recipient as a bioreactor for his or her own tissue engineering organ, and this gives us the reason we name it in vivo bioreactor. This slide summarizes my work here in Zürich for 4 years, and actually we did lots of pilot examinations to demonstrate 3 more advantages of this design. First of all, the medium perfusion will not only support the survival of the cells inside the scaffold, but also on the top of the scaffold, for example, the epithelial cells on the surface of tissue in the trachea, and it might functionally temporarily as a barrier to prevent the ingrowth of the bacteria and also overcome the control the overgrowth of the granulation tissue. And the second one is this design can be used as a cell reseeding device. Because we all know the tracheal cases, most of the tracheal cases are emergency case, and the patient just cannot wait for several months for you to build a tissue engineered trachea in the lab. So in an extreme case, we can implant the scaffold first, and we harvest the tissues, we isolate the cells, and we expand it in the lab, and we reseed it back as in the normal infusion and after the transplantation. And the third one is we can actually make a growth factor cocktail inside the perfusate. It proved to be the most efficient and easiest way to control the growth factor expression inside the tissue engineered trachea. So back to China, actually I proved this one in the animal examinations. We performed, we used the sheep as animal models. We performed almost every month one case for at least 5 years, maybe 6 years. And we also sent the bioscaffold to the Chinese SFDA for the safety test. And we also established a clinical standard cell therapy lab in Shanghai Chest Hospital. And with all these data, we finally get the permission from the government to start a clinic trial. So this is our patient. The patient is a 57 years old male, a heavy smoker, and a complaint of cough and dyspnea for 1 month. And the CT scan actually shows a mass on the left upper lobe, and the bronchoscopy proved the tumor has invaded the left main bronchus. It's 2 centimeters from the carina and totally occlude the lumen. And the biopsy proved to be a squamous lung cancer. And the PET-CT found the mediastinal lymph nodes metastasis without any distal metastasis. And his situation actually deteriorated quickly with the entire left lung obstructive pneumonia and with the hemolysis. And the patient actually refused chemoradiotherapy. He only believed in surgery and also Chinese medicine. So the MDT decided to suggest there might be a sleeve resection for the patient. And we get the permission to use the tissue engineered trachea in case to prevent a pneumonectomy. So the operation actually lasts for 10 hours, and we resect the entire left main bronchus, the left upper lobe, and the superior segment of the left lower lobe. And the size difference between carina and the left basal segmental is huge. So the traditional sleeve resection is a little bit challenged. And we decide to use a 4 centimeters long tissue engineered bronchus. And what we use, the scaffold is biodegradable acylated porcine dermis, ADM. We envelope nasal stent between two layers of the ADM, just to provide mechanical strength. And at the beginning of the operations, we harvest the skin around the incision, and we cut the skin into small pieces, and this surrounded the tissues into single cell suspensions with special machine. And we seeded the epithelial cells onto the inner surface of tissue engineered bronchus 1 hour before the implantations. When we finish the anastomosis, we actually insert 2 catheters from the pores, just between 2 layers of ADM. And we place the pores on the subcutaneously on the left side of the chest wall, which connect to 2 portable pumps, and one actually deliver the because all of the medium is not possible to be used in the clinic, so we only use the longest solution and with gentamicin inside, and the other pump will just suck all this waste out. So the patient was transferred to the ICU right after the operations, and he actually was tubated the next morning, and we continued with the perfusion. And at the 3rd post-operative day, we harvest 20 centimeters, 20 cc blood from the patient, and we isolated the total nuclear cells from the blood, and we inject it back to the inside the tissue engineered trachea. Right after the injection, we stop the perfusion for 1 hour, just make the cells to adhere to the scaffold, and we then resume it. So the perfusion actually lasted for 6 weeks, and we do the reseeding things twice per week, so it's totally 12 times. The patient actually recovered uneventfully. This is the actually 2 weeks after, and the basal section of the left lung is well inflated, and we perform the bronchoscopy follow-up monthly, and we can find what we found is the ADM slowly biodegraded, and the revascularization process flay, and together with the reepithelialization. So this is what we saw 3 months post-operatively. So after 4 months, we can find the intact re-epithelialization of the tissue in the bronchus, and the biopsy proves it's the normal epithelial cells. And we also harvested the waste of the perfusate every 4 hours, and we tested the growth factor inside the perfusate. We can see there's lots of different kind of angiogenesis growth factor inside the perfusate. Since we didn't add any of the growth factors into the solution, and we believe all these growth factors actually might be secreted by the preceded cells, and this is also an indirect proof of the survival and also the function of the preceded cells. So the patient discharged from the hospital 1 month after the operation, and he still refused any chemoradiotherapy and insists on the Chinese medicine. And unfortunately, 6 months after, the CT scan shows the lymph nodes relapse. And we finally persuade him to perform 2 chemotherapy. We used the DP regimen for this patient, and we also used 30-degree the radiotherapy. And the patient gave up because of the serious vomiting side effect, and he actually bought himself with Tarceva, even if it's actually the EGFR test is negative, but he still took some Tarceva, and unfortunately this patient died 13 months after the operation, but it's not connected to the tissue in the bronchus. It's died of the lung cancer relapse. And also here's the lung function test. 2 months after the operations, we can see it's a quite improvement even before, after such a huge operations, his lung function actually improved 10%. So in conclusion, our work proved the feasibility maybe of the in vivo biologic design to be used in the airway reconstruction. And this design actually modified the traditional tissue techniques, and by integrating the in vivo and the in vivo stages. And to the best of our knowledge, this is the first report of a tissue engineer airway patient who can tolerate the chemoradiotherapy. And with all these data, we apply for the Chinese government to step forward for even large scale the clinical application. So